little bit, a lot of things to talk about, and we have a short time to do it in. So I'm Dr. Louis Arancibia. For any of you that have never met me before, I am the chairman of the regional board for GSQN, which is a clinically integrated network that East Jefferson has been utilizing the last couple of years. I'd like to welcome you today to our first town hall this year, and hopefully one of many in the future. I'd also like to congratulate all of our members and our participants that have helped us within the last couple of years. We've had a string of successes within the past couple of years, putting us at the top tier of a clinical organization within the state. And this is thanks to a lot of the hard work that our members have provided us with patient access and clinical integration, as well as patient care, more importantly. And this is trickled down to provide a lot of savings to our payers. So on our agenda today, we're going to talk about the quality and year in review, payer update, our strategy moving forward, as well as GSQN participation, and hopefully we'll have some time to provide a moment for some questions if you have any. One of the main things that it begs repeating, some of course are here today because they're going to collect a check for your participation in the network. Part of this depends on you doing a couple things, and not that many things. One of them is logging into the GSQN website. Our bylaws state that you need to log in at least 8 times within a calendar year. So that's an important metric that takes seconds to achieve. We also need to make sure that we have a valid email on file, because Lena's able to send a reminder to everybody every month so that you can get that login in. And I receive mine religiously every month, and I promise you that if she's got a good email address, she should be receiving it. If you're not, let us know, because there's a possibility that it might be in your spam or some other folder or something's going on. So make sure that if you're not receiving it, then let us know. The other is acknowledging our network quality grid. I'm going to show you an example of that in the next slide. This is essentially the metrics that our payers, partners, are measuring us by. And so these are acknowledged metrics that we have worked with our payers, as well as East Jefferson, to try to achieve. And then obviously, with the quality grid comes the programs for participation in quality networks and quality initiatives. We'll talk about those shortly. The last one, as far as participation is concerned, is something fairly new, and I think it's kind of obvious that it's a good thing, and that's either attending one of our town halls or watching one of our videos that we will provide for those that couldn't make it online. So kind of hard to see, unfortunately, but on our quality grid, I'll be happy to have Lena or Denise send you a copy of this if you don't have it or haven't seen it. Oh, they will? Perfect. So this essentially is somewhat self-explanatory, but it shows the metrics that we're being measured on, like blood sugars, blood pressure, and such. This past year, we met pretty much a good majority of them, but there were a couple that we didn't meet, and we were slight percentages short of meeting them. And most of this had to do with trying to get patients in to recheck their blood pressure or recheck a hemoglobin A1C. Believe it or not, our consultants are also part of this too. They're being measured as well, so somehow those numbers need to get into the system. So if they don't, then everybody that is attributed to that patient is essentially going to be affected by it. So Denise will kind of speak to you a little bit more about what we're doing, and we hope that we encourage you to try to have you and your office staff help us as much as possible to share your patient's information or strategies to get them in, so that we can try to do our best to provide the best care at the most affordable cost. And with that, I'll hand it off to Denise.
So I'm going to just be providing y'all a quick little quality update. As Dr. Arancibia alluded to, our quality contracts, one of the big ones that we work on diligently that takes a lot of our time is the Quality Blue primary care. And it's just that, it's primary care disease focus. So we had our spring tiering. It reflects the care management fees that those primary care physicians that participate, it's reflected in their payment from August of 19 to January of 20. And I'm gonna dive a little deeper into that. East Jefferson tiered in the 4th tier. Previously we were in 5th tier. The care management fees do decrease some, and we are ranked 16th out of 43 entities in the state. So hopefully when we tier in the fall again, so it's twice a year, we'll bump up. And I'm not gonna read this whole slide to you. We will have a link in a few weeks, I believe, that'll have the PowerPoint. But basically, we identify patients with chronic conditions, and we try to provide value and evidence-based care for those patients. And it's an outcome-based structure of payment. And I'm going to also show you the individual measures. And in the little cards on the table have one side is Blue Cross measures, the other side are United measures. But there are certain attribution qualities that the patient needs to have to be in this, and that's one of the diseases. They have to have a face-to-face with the physician, and they have to see them regarding that condition in even less time, but have to see the physician. And we have a database that we actually reach into the EMR and get the data. So as you can see, these are the disease suites: diabetes, vascular care, vascular pharmacy, are they taking their meds, chronic kidney disease, hypertension control, and then they have efficiency measures that looks at some of the possible ways we can help keep the patient either out of the hospital or reasonable. And of course, readmissions is one of those key factors. And it is an all or none, so in diabetes, they have to meet their A1C, they have to meet their blood pressure, they have to either be on a statin, have it contraindicated, and have a controlled LDL and tobacco-free. But you can see it's not 100%, so it is attainable, and we have some physicians that do extremely well, and hopefully will be recognized by the Blue Cross state in the fall. So this is what we look like on the 1st of July. So we have a little bit of ways to go, but it's not unattainable. If you look in that second to last column, that's how many patients we need to get to goal. So it's definitely attainable. For chronic kidney, 13 patients. Diabetes, 5 patients. Hypertension, 4 patients. And then other ischemic vascular we meet, and then the RX is, are they filling their statin? So the physicians who participate in this get a list every month of patients who are not meeting that criteria. Anybody have any questions about that? Okay, I'm gonna go ahead and move on. So we also participate in a care transition pilot with Blue Cross. We began almost a year ago. So we look at any patient that's attributed to, and this is also not limited to Blue Cross, we also scooped in United information as well. So any patient that's attributed to one of our PCPs that's admitted to the hospital, doesn't need to be EJ, it can be Oshner, it can be Orlando General. We get notified of that. So we have a process where all the PCPs, pediatricians, internal medicine, family practice, they get notified of those admits and where they are. So that way they can get those patients in for a follow-up to hopefully reduce readmissions. And then specialists, it's really important for the PCPs to get that feedback. So everybody, almost everybody has a part in this. Anybody who sees a patient does lab work, get it to their PCP. If they have a chronic condition, they need a PCP. So you don't need to be managing their diabetes and hypertension, get them to see a PCP. Gastroenterology, we have a colorectal cancer screening measure. They work wonderfully with us to get those results to the PCP. If we don't have them, they are Johnny on the spot to get them. So If anybody has any trouble, let us know. Lena's been really working hard with that, but they've been great. Endocrinology, Lena's been working on a process for the endocrinologists to get the A1Cs to the PCPs, because that's who needs to have it in their EMR. GYNs, breast and cervical cancer screening, ophthalmology, diabetic eye exams, podiatry, foot exams. So we have a lot of specialists that play a big part in this. And then we also realigned the United measures to make them kind of dovetail into what we were doing with Blue Cross to not reinvent the wheel. So I know this might be a little bit small, but what you can see is we monitor the patients for their meds. We do the cancer screenings, breast cancer, cervical cancer, colorectal cancer screening. And in that darker gray area is diabetes care. Did they get an A1C? Is it controlled? Are they, did they get screened for nephropathy? So the same kinds of things. Well child visits, we do very well on that. And then readmissions. Every insurance company is talking about readmissions. So that's on there too. And then if y'all remember last year, you got a second round of checks, and that was for pharmacy. So that isn't gonna happen this year. I would love to say, oops, we got a second check for you guys. But we really do still have some low-hanging fruit of some possible opportunities to convert to generic if it's possible. We still do have some patients on brand name Crestor, brand name Lipitor. Those have been generic for a while now. So if you can, see if you can flip those patients. If you can, document any intolerances or allergies, be sure those are documented. And then also, statins are so heavily weighted, and everybody looks at that, even the Medicare Advantage. So if they're intolerant, document it, and there is a code for that. And then avoid starting a patient on a trade name with coupons, because they get used to that platinum ring, and then they can't afford because it's not covered on the insurance. I know I flew through that, but in time. Does anybody have any questions? All right. So Jeff is our CEO of Gulf South Quality Network. He's going to talk about contracting.
One of my mentors always told me it was very important to understand your relationship and your actual position in the organization. I'm the guy between the beginning of lunch and the bonus checks on the way out, so I fully recognize that. I'll use my best efforts to move quickly through this. One of the things that we wanted to convey from a board in our committee level is kind of share what our overarching contracting methodology has been. And really this kind of starts with some of the things we were talking about, is really that foundation we built with the Quality Blue Primary Care Initiative. Because this was something that was simple enough and straightforward enough that we got a lot of buy-in in the process of establishing those guidelines in the program. And it makes it subsequently so much easier when, from a strategy perspective, we simply find other payer relationships that act like that. That also serves to relieve a lot of the administrative burden from having to learn new metrics or having to, quite frankly, produce a lot of additional effort and paperwork chasing these results in these payer contracts. The second thing, and I can't stress this enough, is we've worked very hard, especially over the past year, and working in a very aligned manner with the hospital, employed physicians, and the community physicians. We literally show up at the table with the payer together in lockstep in an effort to try to get as much influence as we can in that relationship versus contracting or trying to establish these relationships in silos. As I hinted a minute ago, part of the strategy is really finding other relationships that align with that Quality Blue Primary Care type premise, and then merely cohorting or finding other patients that look like those patients and putting them into those workflows we've already worked so hard in establishing. We've maintained a non-risk or upside-only relationship with all of our payer contracts. In my 30-plus years of managed care experience, risk is a dirty four-letter word, unless, of course, you have a different way of spelling it. We have very specifically shied away from those relationships, and part of that really is because we need to develop the adequate infrastructure to be able to meet the rise in the road, no matter what type of value-based care arrangement or similar pay arrangement comes down the pipe. I talk a lot in our shop and in some of our committee meetings about it's all about our PMPM. It's not the payer's PMPM. It's really understanding how all of us work together, how patients move through that system, and the resulting utilization and spend across that entire system. QBVP, Quality Blue Value Partnership. This is our largest contract. We've been in it since the very first iteration of the contract. It's what's called a total cost of care contract, meaning that we are looking at a fundamental calculation of our performance based on the entire spend of that population. It has certain tiered shared savings targets with it. And as all these contracts have, there is a quality gateway. In other words, you have to basically prove that you're not withholding care to save money. So in addition to that, we have had our second year in a row of some pretty good success with the program. And I think it's important to kind of see some of these numbers. And I'm always accused of being the numbers guy in the room, but I started out in the actuarial department of an HMO, so I can't help it. There's a couple things I want to show here. First of all, we're talking about pharmacy, and you all did an amazing job in 2017. When I talk with payers, when we meet with them, when we talk about the areas where we've really moved the needle, it's what's called the halo effect, which comes off of managing those folks with the chronic conditions. But where we really got the zing was really on the pharmacy side. And this is one of those areas where, as we're compared year over year, we move the needle so far, as Denise alluded to, we had a second distribution last year, all because of pharmacy. You're compared to the year before. So we kind of got the fat out of it, but there's still, the good news is there's still some fat there. And when we're looking at the dollar amount on aggregate in that population, in the 2017 year, we had almost $19 per member per month savings. So better than the year before, we saved a whole bunch of money. And that's how that subsequently has been trimmed down to $4 per member per month. One of the things that has changed within Blue Cross that I think is important to kind of point out is, like a lot of payers, they have a playbook that basically says, for efficiency's sake, we need to get all of our contracts aligned in a certain way that makes it easier to administer. So part of what's now changed with Blue Cross is the standard by which our bonuses are distributed are not based on hitting certain overall population targets. It's actually a combination of a risk-adjusted total cost of care and your Quality Blue primary care tier. So every time we move a tier, that net result on how much we can earn drops by 4% or increases by 4%. So what they've basically done is said, well, providers, you're doing a great job, but we're going to really put your feet to the respective fire, because now you're going to have to not only manage those costs well, but you're also going to have to make sure that you're moving the needle with respect to that chronic population. So the last thing that I would talk about with them, and I think this is important, and we've had this, Dr. Ansby and I talk frequently about this, is kind of understanding what we kind of call the scope of influence. So when we're looking at all of these patients, and I would use a very simple rule of thumb. If you're looking at your average commercial member, that person their spend is about $500 a month, just like easy math. I like easy math. Okay. So as we're looking at this patient population, and we think about all these patients moving through your practices and through the hospital here, in the last 12 months, this has now increased over 17,000 Blue Cross members, and they're seeing all of you. They're your attributed membership. You're looking at $76 million in med-surg spend. So it doesn't seem like there's lots of patients, but when you start adding up the numbers and you look at the total aggregate for that population, That's $94 million worth of expense that has touches with all of you in the hospital, where as we go down the road and build some of our capabilities, we're gonna have a better understanding of how these folks move, and we're gonna have that better ability to drive them into your practices and into the hospital for the best bang for the buck on these contracts. We signed our first Medicare Advantage contract, also with Blue Cross. And again, this is very much so following that strategy of parallels to programs we already know and perform well. And in this program, it's a little bit more focused with respect to being hypertension and diabetes with some pharmacy compliance incentives. There is an overall quality incentive available. It's $8 per member per month based on our final results at the end of the year. There is a small shared savings opportunity of 30%. So that sounds pretty good so far. Population is only 425 patients. So the good news is that we're starting out with a very small population, and we can manage it a little bit better as we implement it. We haven't had to make any real changes to our infrastructure to be able to do this. And again, as we're going to talk about in a second with United, all of this is aimed at making it a very focused strategy, making it as simple as possible with the best possible clinical and financial outcome. We just signed a new contract with United. It was our first renewal in their ACO program. And I can say anecdotally, because they wouldn't put it in writing for me, but they said that you all and another clinic in Mississippi were the only two sites that have made bonus every year and made the quality metrics every year in their first contract term for the region. So that's kudos. This is a slightly different version of the shared savings contract in that although we have a 50-50 share with them, the way some of the patients are actually calculated at the end of the day, it's a little bit of a challenge to